Good evening, guys. Welcome to another one of our installments of our virtual health fairs. Happy to see you guys here today. And Dr. Backus and I just wanted to kind of put this together to answer some questions people have about screenings, especially when it comes to cancer screenings, because we know the cases of cancer are slowly on the rise, although, our ability to catch them sooner has gotten better. But it's always good to kind of bone up and know exactly where you stand on the spectrum in terms of do I even bother? So that's what we want to kind of just give you guys a little bit of a taste of what this is, and also to answer your questions towards the end of the actual presentation.
Yes. The month of March was a National Colon Cancer Awareness Month, the whole month, just because colon cancer is one of the most common cause of cancer and also cause of cancer death. So we thought that this was a good opportunity to kind of address the most common cancers and screening that are in place. So we'll be going through the main ones, especially, as I said, the most common and the ones that are the highest cause of cancer deaths. And we'll be telling you what the recommendation on the screening is. And there's some others as well too that we get questions about that there are no hard recommendations on, but we'll also touch on those and let you know, basically what we usually do in our clinical practice and what we recommend to our patients. And so you'll have the opportunity to ask questions as well. We ask that you ask it in the chat box, so that way we don't have too many voices coming over the presentation. And we are recording this, so we can always send this out. We will send it out to you after we're done with this webinar. Alrighty, so as we said, colon cancer, this is Colon Cancer Awareness Month. So we're going to start with colon cancer. It is one of the most commonly occurring cancers and one of the highest cause of cancer deaths. Not the top, but it is with the others at the top. We're going to talk a lot about what's called a USPSTF recommendation, and that just stands for the United States Preventative Services Task Force. So it's a lot to say in a mouthful, but they're the ones that make the recommendations for basically all the cancer, and not just cancer, but other screening recommendations, testing. So if you go to their website, you can find all their recommendations there. They base their recommendations on clinical data and trials that's been vetted. So with respect to colon cancer, they recommend starting the screening for colon cancer at age 50 and continuing to age 75. So let's kind of break that up a little bit. So the starting age of 50 is for the average risk population, meaning that if you have no family history of colon cancer, or you yourself have no history of colon polyps and no symptoms, then you would be considered average risk, and you'd start at the age of 50. There are certain populations that we would want to start earlier. One of the more recent recommendations for African Americans, they tend to have a higher incidence of colon cancer. So it's recommended that it start at age 45 for that population. If you have family history of colon cancer, the usual recommendation is starting at least 10 years before the youngest diagnosed relative. So let's say if your mom had colon cancer diagnosed at the age of 55, you would then start at least by the age of 45 to have that screening, because you're at a higher risk. There are also some genetic syndromes that are hereditary or familial, meaning that they are commonly passed on from generation to the next, such as Lynch syndrome. That's the most common one, I would say, involving colon cancer. And so when it comes to those increased risk population based on familial syndrome, the recommendation is actually dependent on that syndrome. So depending on the actual type of gene mutation, then there would be strict recommendations as per how often you should be screened, what age you should start, etc. The screening after 75, because we both have patients that are well over 75, and we have some patients who do not continue screening, whereas we have some others that would like to continue. Now, this is all individualized based on your current medical situation, based on your chronic conditions. You know, it's a decision making, a joint decision making between you and your doctor. We'll sit down and talk about the benefits and risks and see if, you know, the benefit of having a colonoscopy at that age, based on your health at that time, if that outweighs the risk of the colonoscopy or whatever we're going to be using to check for colon cancer, which we're going to discuss in the next slide.
So basically, it's not a hard 75.
Mm-hmm.
And I've had this discussion with some of my patients, you know, past 75. What do I do? And like Dr. B said, it's all based on where you are health status wise. You know, if you have multiple comorbid issues that are, you know, we're having a difficult time controlling, you're seeing many specialists, and it's just not going to be worth your time, or the going through the process might be more detrimental to you, then we have the discussion, and then we decide to move forward or not.
So colon cancer screening, what do we use, right? I know most people know what a colonoscopy is, and this is the gold standard for colon cancer screening. It is done usually, it's every 5 or every 10 years based on findings and family history. You could have your GI doctor tell you that it may be sooner. Some may recommend 3 years, depending on what they found on prior colonoscopy. So depending on the amount and the size of the polyps, or if there were any precancerous polyps, so based on a biopsy report of that as well. And also based on your personal history. If you have a pretty strong family history, they may want you to do it more frequently than the regular population. There are other endoscopic procedures, endoscopic meaning that visualized by a camera. So these two, sigmoidoscopy and capsule endoscopy, can also be used. They are not a definite replacement for sigmoidoscopy. For instance, it only scopes half of the colon. So, you know, you can probably detect cancer on the left side of the colon, but it doesn't go further than that. It doesn't go, you know, in the first half. So that's the downfall of the sigmoidoscopy there. For capsule endoscopy, it's swallowing a tiny camera, and you're going to take multiple photos as that capsule goes down into the colon. And again, it's not a direct visualization. It's based on how many photos are taken, and it's usually not a standalone test. But in the event that you have an incomplete colonoscopy, whether the prep wasn't great or they weren't able to complete it because of some difficulties during the colonoscopy, this can be done as an add-on test. And then there's now the stool test. Well, there's been stool testing around, but the latest one that everyone asks me about is the Cologuard testing. Mm-hmm. So we'll go through the different ones. So there are two regular blood detection for stools. There's one that's called a FIT test, the fecal immunochemical test, one called the FOBT, or the fecal occult blood testing. And they both test for you basically, you collect a sample of your stool at home, you put it on a little card, you send it in. They both test for hemoglobin or blood in the stool. They use a different chemical way. That's why they have different tests. And actually the FIT test has been proven to be more sensitive for picking up blood in the stool compared to the FOBT. So if we were to choose one of those, we usually choose the FIT testing. In the last few years, Cologuard has arrived, and it combines FIT testing and DNA testing. It checks for DNA of abnormal cells. So if you have a cancerous mass that's shedding cells into the stool, it will detect those abnormal cells. It can detect some cancerous polyps as well, but sometimes not precancerous polyps. So again, not the gold standard, but it's definitely more sensitive than the FIT or the FOBT testing alone. And there have been cases shown that the sensitivity of using a Cologuard test with respect versus a FIT test yields a much higher sensitivity in terms of detecting colon cancer. Of course, if any of these testing are positive, then you will need to have a colonoscopy. So general recommendations that we usually, we tell our patients at first, at the age of 50, we do recommend colonoscopy as the first testing. And then depending on what you find then, and depending on your family history, then we can guide you in the direction of where you should go. I don't know about Dr. Morris, but some of my patients don't like the thought of having a colonoscopy. So, we would discuss all the benefits of the others with you.
And just one that we left off the slide intentionally, not to create any confusion, was the CT colonography. Mm-hmm. Now, what that is, it's a CAT scan composite picture of your colon. Not used very often because it can miss cancerous polyps. It's one that we reserve for patients who've had significant negative issues or perforations, or they're at risk of perforation from doing the actual colonoscopy, which is which can happen. It's very, very, very minimal. But if you're at higher risk for that, or you've had prior surgery on the colon, then some patients have elected to get the CT colonography, and that's usually only done at very specialized centers. Mm-hmm. And I think Banner is one that does do that in Tucson, but it's not the gold standard. And it's always done with the caveat to tell a patient, hey, you know what? Because of XYZ in the past, we're going to have to use this, but bear in mind, it's not as effective as, of course, the real colonoscopy. So some people, what they do is they marry the CT colonography along with the FIT test. So that way they kind of cover as much ground, so to speak, as possible.
Right. And also the CT is a little bit difficult to get covered by certain insurances too. And usually they would recommend that you have to have one of the other, like fail a colonoscopy, mm-hmm. or have, some kind of contraindication to having a colonoscopy. So it's not something that we typically do on a regular basis, no. Only on a very individualized basis. All right, breast cancer screening. So of course we had to talk about breast cancer, although there is going to be another month that's going to be dedicated completely to breast cancer, because it is the most frequent cause of cancer death worldwide in women. The majority of breast cancer is detected throughout the screening test. So that's why screening test is very important, mm-hmm. With respect to breast cancer. And USPSTF recommends at least biannual screening mammography from age 50 to 74. So that means at least every 2 years. We can start earlier again, and it's recommended to start earlier depending on certain factors, like we spoke about with colon cancer. If you have family history of breast cancer or family history of gene mutation, the most common, most of us have heard about the BRCA. There's a BRCA1, BRCA2. That's the most common familial gene mutation. So the one that's most commonly passed on from generation to the next. Then you would start at an earlier age. Typically, it depends on the mutation. It will then trigger a certain age to start by, or based on the family history of breast cancer. Again, that 10-year rule stands for breast cancer as well. So the earliest diagnosed family member with breast cancer, we will start the women in that family screening at least 10 years prior to that. Of course, if you have personal history of other related cancers that puts you at risk for breast cancer, screening will start early as well. Prior use of hormones, especially earlier in your life, any kind of estrogen containing hormones do put you at higher risk for breast cancer later on. And a history of radiation to the area, whether it be, some other cancer before or some other medical issue that you have to have radiation for, that does put you at risk as well too for increased risk for breast cancer. So typically my patients, I tell them we need to get you a mammogram every 1 to 2 years. Try to keep it on an annual basis, because some mammograms, if there's a small mass, mammograms can miss certain things. And so if we do it on an annual basis, you'll pick up they will be more sensitive for picking up very small cancers or very small masses that might be suspicious. And there are different types of mammography. The most recent one is the 3D, which tends to give the better picture, the whole 3D of the breast tissue. But sometimes we're not able to obtain 3D based on where we're sending you for the radiological center, basically. And so some areas are limited for this, but that has become more of the gold standard now. That's what I usually recommend to my patients, getting a 3D mammogram. For that abnormal findings, you may need to go back in for diagnostic mammogram. Let's say if they picked up a small mass or a cyst or some increased vascularity, which means increased blood flow to the area, you may go in for extra diagnostic mammogram and ultrasound. And there are times when an MRI would be recommended, and that's based on your family history and your own history. So there's a way that they calculate the risk of breast cancer. It's a lifetime risk. And generally, when you have more than 25% lifetime risk of breast cancer, an MRI is indicated at that point. Of course, many of you may know that males are sometimes at risk for breast cancer too, so we can't forget about that. There are no screening recommendations for asymptomatic or no family history for males right now, but if there is a presence of a BRCA gene, then it's recommended to have a mammogram once a year. So that's a really only hard recommendation for males at this time. And I did want to throw this in there, the latest recommendation, because now everyone is getting a COVID vaccine. Hopefully most of you have gotten yours already. They've been finding that some of the COVID vaccines are inducing what we call axilla adenopathy, which are the swollen lymph nodes under the arms. And so that's causing some suspicious findings in mammograms. So when they do your mammogram, you're looking at your axilla under the arm as well, because that is where any kind of, if you have any breast cancer or any infections or anything, that's where it drains to. And so after the COVID vaccine, some people have been having swollen lymph nodes and has been producing some suspicious findings in the mammogram. So it's recommended, if you can, have your mammogram before the COVID vaccine to do so. But if you did have the COVID vaccine already, waiting at least 6 weeks after the last shot, whether you had the 2-shot or the 1-shot vaccine, waiting at least 6 weeks before going in for your mammogram to avoid the false positive results.
And the swelling in the lymph nodes is really just your body's reaction to the vaccine. It's not anything abnormal. Some people get it, some don't. It's just that you don't want there to be any fog in the mist when you're dealing with breast cancer or breast evaluation. So always safe to kind of wait a while before you get that screening test done.
Yes, I've had a few patients who had this happen. They went in right after their COVID vaccine, and then they had to go in again. So, you know, you're going to have to go in pretty soon after for follow-up if they did find swollen lymph nodes. So we're just trying to avoid that unnecessary follow-up testing if needed, if we can.
Let me ask you a question, Dr. B, before we move on. What about women who have breast implants?
So for women who have breast implants, it is still recommended to have yearly screening mammograms. Most people who have breast implants more for cosmetic reasons. And so you still have your native breast tissue, call it, behind or in front. It all depends on where they place that implant. So mammograms have come a long way. The digital mammograms now can actually see around the breast implant. And when you go in to have your mammogram, if you have a breast implant, you need to let the technician know, because they do additional views as well to make sure that they're getting all that breast tissue that the implant may obscure. So yes, it's still yearly, every 1 to 2 years for mammogram with breast implants, and you definitely want to continue to have those screening tests. Okay.
So lung cancer screening, it's kind of one of the newer kids on the block, because we never really had much of anything in terms of ways to screen people for lung cancer. So what's come up is what we call the low dose CT. So it's a CT scan. Now, I'll backtrack with lung cancer. It is the leading cause of cancer-related deaths among men and women. And I mean, we all know one of the major, or probably the most common cause of lung cancer is what? Smoking. So with regards to reducing your risk of getting lung cancer, quit smoking or don't pick it up in the first place. But that aside, you've lived your life and some people have smoked. Now we got to figure out, how do we kind of mitigate your risk? How do we look and keep an eye out for those disastrous things in the future? So what the recommendation is, from ages 50 to 80, especially if you have a 20 pack year history of smoking. Now what pack year means is it's a calculation we do. So it's like 1 pack a day for 20 years. So that works out to be about a 20 pack year. So it's all based on punching in some numbers. And basically you've been smoking in the past 15 years prior to get your screening at least. So those, my lifelong smokers, we definitely are having this conversation more often. Okay. Now you may ask, but doc, why 50 to 80? Let's start at 35, because I've been smoking since I was a teenager. Let's start earlier. The problem is, when you're younger or before the age of 50, the lungs go through many, many changes. And you can see what we call inflammatory nodules that can be picked up on CAT scan, and those tend to be false positives. So doing earlier screening is not beneficial to you as a patient, because now it puts you on that path of, well, he found something, I was 35, now I got to follow it up. And it just means, for the majority of patients, unnecessary exposure to radiation, as well as just the dread and the worry of what could this be. And you can get nodules based on a lung infection, a bronchitis. I mean, living here in Arizona, where we have valley fever, that can cause, little nodules in the lungs, and the nodules do change. So the recommendation showed, the highest data and efficacy came between the ages of 50 to 80. Because at that point is where we see a lot more of the mature type negative lesions showing up and can be caught.
And the low dose CT means that it's actually a lower dose of radiation than the regular CT of the chest. So it is a reduced dose, and that's why it's recommended that we can do it yearly, just for just for screening purposes.
All right, so the other cancers, or the other kids on the block that we always are keeping a lookout for, but for the majority of them, there's not any hardcore evidence or data to support doing frequent screening for. Except, let's start off with cervical cancer. So it is a common cause of death. It's declining because, with screenings and pap smears that women are doing, and now the Gardasil vaccine, which is available for children, I think is 9, and they've extended to 45 years old now. Exactly. So from 9 to 45 will reduce the risk, because cervical cancer, the primary driver of it is the HPV virus. We know that. So we pretty much have this one well controlled. And to be honest, with everything, prevention is better than cure. So safer sex practices. So we're counseling our patients using condoms, having one partner, just kind of being safe, protecting your body from this scourge. HPV testing, the PAP, I think, is done every 1 to 2 years or every 3 to 5. It all is based on your level of risk. So this is a discussion you will have with your doc, Dr. B or myself, if you're in that age group, and we figure it out.
Yeah, many years ago, it used to be a yearly thing for the pap smear. Then after the incident started declining, based on all the factors Dr. Morris spoke about, it was moved to every 3 to 5 years. And this is for women who had normal pap smears and no high risk behavior or no presence of HPV. But now, even with even more decline in incidence, we had the recommendation moved up to every 3 to 5 years. So I have most of my patients getting their pap smear every 5 years now. But again, based on your previous history and previous pap smears, it may be more frequent than that.
Now, prostate cancer. So the big governing body, the USPSTF, they officially have no guidance with regards to screening for prostate cancer. And they've actually gone one step further to say that using a digital rectal exam does not show to be, there's lack of evidence of using that as a screening tool. Now, when you talk to urologists or even myself, when I counsel my male patients, I do recommend, periodically getting a rectal exam, because some things you can catch on the exam. And the PSA blood test, which is right now one of the, I think, the only readily available test from a doctor's office, and by no means it's not 100%, but it is what we have. So I counsel most of my male patients, and Dr. B as well, to get the yearly PSA. That way, and the reason for getting it is not just to forget its sake, but we're looking at the trend.
Mm-hmm.
So what we're looking for is basically, if your PSA, I'll just give some numbers. If you sit in the 1.1, 1.1, and all of a sudden on year 4, you're 2.8. That's a jump. That's a big enough jump. So we're looking for a 30% increase in that number from one year to another. So, and that kind of alerts us that something's going on. Now, it could be maybe an infection, but at the same time, seeing that and looking back at the trend, it guides us and guides the patient to be able to get the proper evaluation done, whether it be with a urologist or with myself. And I mean, we have the discussion.
For ovarian cancer, again, the U.S. Task Force had no hard recommendations for screening. The only thing in place for screening ultrasound for ovarian cancer are women with known high-risk hereditary cancer syndromes in the family. So going back to like Lynch syndrome, there's some other syndromes that puts you at a higher risk for ovarian cancer. Then only if you have those known syndromes existing, then we would send you for screening ultrasound. Of course, if you're symptomatic, meaning if you're having any pelvic pain, bloating, and just not feeling well in that pelvic area, then I would send you for an ultrasound as well, just to rule out any masses or any abnormalities on your GYN organs, especially your ovaries. So of course, if you're having any kind of lower GI or pelvic syndrome, you need to let us know so that we can order the relevant testing for you.
And skin cancer. Well, we live in Arizona. The sun is everywhere. So with this as well, prevention is better than cure. But for the majority of us, myself, Dr. B, those in our practice, we kind of fall out of that age range of prevention, which is 6 months to 24 years old. So what do you do after that? Doc, I'm in my 30s, 40s, 50s, 60s, 70s. What do I need to do? So that's where we recommend that patients get at least a once-a-year examination with a dermatologist or even with us. And it's always good to take a look at yourself in the mirror, a good long look periodically, because little things pop up on the arm, on the chest, and you know your body better than we do. So that way you can alert us, which all of you, I must say the majority of you have done really well, when you notice something is just not right. Like, for example, doc, this particular skin lesion, it flakes, it bleeds sometimes, been going on for 3 to 4 months. Those are things we look for. We look for asymmetry, we look for color changes, we look for frequency of bleeding, we look for growth patterns. So all these things we look for. So, and I know some things that are normal and benign can look scary. So I tell patients, don't be afraid. Whatever, if you think it's new, or we'll take a look at it. That's just to kind of prevent the scourge of skin cancer. Now, if you have a family history of melanoma, you're high up on the list in terms of getting in to see dermatologists on a more frequent basis for a full skin evaluation.
Yes, especially if you have family history of skin cancer, particularly melanoma. We do encourage you to see the dermatologist. That's their specialty. That's what they're trained in, to pick up on those, especially those areas that may not look like outwardly suspicious, but they can pick up on some subtle changes. All right, so that's what we had for our cancer screening tonight. We want to ask for any questions that you may have.